Good morning to all of you, and welcome to this really important symposium. I think it's going to be a great day. We're very excited that you're all here, and for those of you from out of town, that you've braved this very chilly weather that we're having in Canberra at the moment. I'd like to also start by acknowledging the traditional owners of this land, the Ngunnawal people, and paying my respects to their elders past and those who are present here today. The audience here today represents, I think, the full spectrum of preventive health research system participants, if I can use those words, from the research institutions, state and federal governments, the non-government organizations, primary care industry, and the community sectors. So we think it's important to provide opportunities such as this for interdisciplinary and cross-sectoral dialogue, and that's really a key part of what today is about. Now, part of our aim for today, as Gail has mentioned, is to really showcase leading examples of policy-relevant research for preventive health and to promote the integration of research, policy and practice, and to support the growing dialogue between these domains. The agency, as you know, was established by the Australian government to strengthen Australia's investment and its infrastructure in preventive health, and its establishment was supported by the state and territory governments through their partnership on prevention. Our functions include facilitating research infrastructure for preventive health, and we've been using the Preventive Health Research Fund in a variety of ways to do that. We also aim to drive the development of dynamic knowledge systems that enable evidence-informed policy and practice in prevention and in health promotion across Australia. And to support this aim, we're holding this symposium as one of the things that we're going to be doing for researchers, policymakers, and practice areas to discuss the co-production, if you like, of policy-relevant research and to share recent developments. Today we're also launching the strategy, the National Preventive Health Research Strategy that will build knowledge for a healthy Australia. The agency has led the development of this, but I have to say the strategy has been dependent on an enormous number of contributors, and let me thank you all. I think probably every single person in this room has contributed to that strategy, and some of you extensively. I can't thank everybody, but I particularly would like to thank our expert committee on research for their support, for their advice through this process of creating this national strategy over the period of its two major consultations, and in particular to acknowledge John McCallum's leadership. John from the NHMRC is a chair of our expert group on research. Stakeholders told us as we were consulting them that a high priority for research infrastructure development was applied research, including translational research to support policy and program development and the evaluation of policies and programs. And the agency was asked to be a leader and a catalyst in supporting the development of the appropriate preventive health research culture. So this ongoing role requires facilitating the community and decision makers in working together on determining research priorities and approaches. So we're pretty excited to be launching this strategy. It was a long time in creation, and I think that time was very well spent in understanding really what our contribution, what our value add, if you like, is to the whole of the research in health in Australia. So to launch this strategy, I'd like to introduce Professor Warwick Anderson, the Chief Executive of the National Health and Medical Research Council, which is, of course, Australia's major governmental funding body for health and medical research. Professor Anderson has a long background in the research sector, and I'm not going to list his many achievements. I think most of you will know them extremely well, but I will mention one thing of which I'm aware, and especially note his contributions and leadership as part of his role with the Global Alliance for Chronic Disease. Please join me in welcoming Professor Anderson.
Well, thank you very much, Louise, and I find excruciating that introduction, so I really thank you for not saying anything good or bad. Thank you. So, look, I'm absolutely delighted to be here to launch this National Preventive Health Research Strategy, and Louise, thanks so much for inviting me to do so. I too wish to acknowledge we meet today on the land of the Ngunnawal people and to again commit the National Health and Medical Research Council to at least 5% of our funding being of direct benefit to Indigenous health, and I'm pleased to say we're running a little bit above that at the moment. It's good to be here with the sister organisation, we're going to call it the agency, right? Because I think since ANFA was first set up, we have had very close and productive relationships between the two health funding agencies, these two health funding agencies within the health portfolio here in Canberra. And I too would like to acknowledge the role that Professor McCallum has played in my organisation, but also as chair of the Expert Research Committee here. We've done a lot of collaboration behind the scenes in terms of peer review processes and staff interaction, which has all been extremely positive. And Louise, thank you for making that work really well as well. And not yet formally announced, but I gather Andrew Wilson's going to talk about it already, anyhow today, a partnership centre on prevention that will be jointly funded by the NHMRC and a number of other agencies, which we're expecting the formal announcement of very shortly. I suppose, like our overall aim at the NHMRC too, this strategy is meant to be transformative. It's a word that we use a lot in our new strategic plan as well, because there's a general recognition that a new age has dawned in terms of the interaction between researchers and the broader community, not just policymakers, practitioners, but the general community as well. And that is a challenge. It makes life more complex for researchers, but also makes things much more interesting. We've acknowledged that at the NHMRC through a number of new funding schemes, not just the partnership centres, but our partnership projects for better health, which are now open continually. They don't close, you can apply at any time, and they are a partnership between, on the whole, policymakers, government and non-government agencies and researchers, and currently we co-fund with 144 different organisations research, not funding organisations, but organisations with a need for policy-based research. But this is a terrific document. I'm sure you've all read it, and the focus on it today will be terrific. And for do intend it as a national resource to provide guidance on how to make the best use of what will always be limited research funding. And so not only is it to make best use of limited resources, but also to maximise effectiveness of public health interventions by basing them firmly on research. The expert committee, led by John, that came up with this policy has many of the names that you would expect on the committee, and so when you look at the members, you can see that the quality of this strategy reflects excuse me, the quality and experience of that committee. But numerous stakeholders have contributed ideas, and I'm told there were more than 50 written submissions from a broad range of individuals and groups that included government agencies, individual researchers, professional associations, community organisations and health promotion groups. And the very capable Margaret McDonald, who's sitting up towards the front here of McDonald Wells, did the hard task of taking all that and putting it together. And I'm told here in my notes, Margaret, that you did that with patience and insight. And knowing you personally, I'm sure that's absolutely correct. As the strategy makes clear, prevention is really a multifactorial, complex matter. And getting effective prevention from the discovery of knowledge is really a complex path involving many, many stakeholders, and I think the strategy really is an excellent description of that. Nobody thinks prevention's a bad idea. It's just damn hard to achieve. And we have seen in Australia over its recent decades many attempts at prevention by government and public agencies that, despite great intention and much investment, in fact, they have achieved less than they should. And I think this strategy really points a way that how we can do better in that way in the future. Of course, prevention in our own country is important, but prevention internationally is also important, and the opportunities for research to inform implementation of preventive strategies in low and middle income countries is immense, and that's why the NHMRC has from day one been a foundation member of the Global Alliance for Chronic Disease Research, and we're about to roll out our second coordinated international call between us, Canadian Institutes of Health Research, the UK MRC and NIH, together with agencies in China, India and South Africa. It's a very exciting initiative. Damn hard to work internationally because we all, especially us government bodies, have our own rules, but we've done one coordinated call, and we're about to do a second one and do coordinated peer review, which is another really interesting challenge. Depending on which keywords you put into our database, and people always argue about this, no matter what field we're talking about, we think we fund around $150 million of prevention research at the moment. But as I say, it does depend on the keywords, could be more or less. So congratulations again to everybody involved in this strategy, and for accepted the challenge of coming up with this strategy in 2011. And I think they've achieved a really marvellous document with the 4 building blocks of research, people, culture and supportive systems. Knowledge links all those. And each of these building blocks needs, of course, to operate in a complementary manner in order to establish the entire ecosystem of research in this area. And the point that the strategy makes many times, and it's an absolutely crucial point, is that knowledge flow is not unidirectional. We tend to think translation, discovery, off somebody to make use of it. But of course it has to be both ways. The research agenda has to be informed by the system and its needs and the people who we hope to make their lives better, the community itself. There are specific priority questions for tobacco smoking, the harmful consumption of alcohol and obesity being developed. Indeed, the tobacco one has already been published, and I think that's another important part of a strategy. You need an overall strategy, but you also need a targeted one. And every day I look at the press clippings for the NHMRC. Our alcohol drinking guidelines are mentioned, I think, pretty much every day, usually along the lines of, well, there are these guidelines, but nobody's taking any notice of them, so that's why we need a strategy. I hope you, I hope we, I hope everybody will use this strategy. I recommend the strategy to you. It's available out the front, it's available through ANFA's website, and again, let me congratulate everybody involved in developing it, and have a very productive day. Thank you.
Thanks very much, Warwick, for launching our strategy, and we're looking forward to working with the NHMRC and a whole lot of other funding bodies into the future in relation to some of the guidance that we have put, with everyone's help, into this strategy. We're delighted now that the strategy is launched, and thanks again, Warwick, for doing that. He did mention that there are 2 parts to the strategy, and it is not entirely completed. So there's the overarching strategy that Warwick has just launched for us. There is as well the specific priority driven agendas in each of our 3 areas that health ministers have asked us to work on. So here's the tobacco one, a very interesting process in its own right, and we're pleased to have that out. It's now available on our website and in hard copy for you today. So we hope as well as Warwick said, that you'll share these documents very widely. In fact, we have put in our key performance indicators in relation to our budget papers that we present to the government that the citations around this strategy and the priority-driven research agenda is part of our KPIs to government to say that people are actually paying attention to this work. So thank you very much, and thank you again, Warwick.
Thank you, Gail. Thank you, everyone. It's a great privilege to be here. I'm going to talk very fast because I thought it was 20 minutes. I'd like to acknowledge the traditional owners of the land and their elders past and present. And I'd also like to... Say it again? Yep. Slowed down already. Okay, I'd also like to acknowledge, in particular, Rebecca Armstrong, who is here today, Tana Petman, who are my colleagues, partners in crime, if you'd like to say, in terms of knowledge translation and evidence-informed public health. But there are a large range, many acronyms you recognise in terms of our funders, and in particular, the Jack Brockhoff Foundation, who funds me. So the presentation this morning is going to cover just some brief concepts of evidence-informed public health and knowledge translation to set the scene. I'm speaking from my perspective in terms of some of the experiences that we've had in establishing knowledge translation partnerships, rather than speaking broadly on behalf of all the partnerships and all the KT out there, but it will give a heads up to some of the issues that we've experienced through the partnerships themselves and the processes and content that we've gone through. There are learnings at the end, and there are issues that I think as a group it'd be really good for us to harness, talk through these things and work out how we keep moving forward together. Oh gosh, is that the week to say moving forward? Anyway, I'll keep going. Evidence-informed decision-making. So evidence-informed decision-making, the main principles here are researchers and decision-makers, whether they be children themselves, whether they be Prime Ministers, whether they be anyone involved in the decision, need to work in partnership to fund and conduct research that addresses key policy and very real contemporary questions. Research needs to be conceptualised together, conducted and communicated in a way that's meaningful to everyone who's part of that decision-making process. And then finally, research evidence needs to be accessed, assessed for its trustworthiness and appropriately applied by decision makers in their context. And some of those contexts are extremely complex political systems. So in terms of KT, there are 3 main components that appear to be the driving elements within the literature and the science. There's push, which are predominantly researcher-focused interventions, ones that we historically have been involved in terms of disseminating research out to users, potential users. There's pull, decision-maker-focused interventions, which are generally used to change practice. There's a demand-driven approach to them. There's a need to identify an issue and examine it and set it within the context of how that information will be used. And then there's exchange, which are primarily these partnerships between researchers and decision makers where questions of mutual interest are identified, research is conducted in partnership, and the research is used to inform policy level, but also child level, every level decision. So the program that I lead, and I'm here with 2 hats today, I lead a primary research team which comprises primary research, secondary research and knowledge translation. But I've also got a hat on which is the coordinating editor of the Cochrane Public Health Group, and I'll talk a little bit more about that later. But primarily the research group that I lead, its main aim and vision is to make a difference to child health inequalities from a public health perspective. And the key components that are required within that are not just research, but knowledge itself, advocacy, building capacity, and a sustained capacity across all of those elements to affect systems, services, environments, determinants, behaviours and a whole variety of outcomes. This may be a little bit tricky to see at the back because I think the light's on, but really it's just an image to portray the myriad of different circles of influence and spheres of influence that need to be considered when you're thinking about the complexity of research questions and the issues that impact on those research questions. So children sit within a family, families interface with workforces and communities themselves, workforces sit within services and systems, services sit within programs and programs sit within policy, and there's of course a number of other factors that are probably left out. But really it's just to convey that we're not talking about a single level system here or a single level group of contributors, but a whole range of contributors, each of whom have a contribution to make and also a need themselves. So the mission of our program is to generate high quality evidence to inform policy and practice to reduce health inequalities. And we do this by answering the questions around how can evidence-informed decision-making be promoted? And that includes not just the production of summaries, evidence summaries and systematic reviews, but the science behind knowledge translation, what works for who, how much does it cost, what are the strategies that are going to work for people in local government, what are the strategies that are going to work for consumers, what are the strategies that are going to be useful for lobbyists. I'm going to trip myself up soon. Hold that bell. There's a range of research which is fundamental research around what influences health and wellbeing, our traditional epidemiological research, qualitative research, hearing the voices and experience of children, families themselves and others. And then there's a strong platform of solutions-focused intervention, prevention intervention initiatives and health promotion initiatives to really understand what works in this space. This will be very difficult to read right now, but you will get copies of it. But what I was trying to convey through this image here, on the left-hand side, the different methodologies, if you like, that help answer the question of what influences health and wellbeing, what are the different components that need to be included in research around intervention research, which needs logic models, it needs development of interventions, it needs pilot testing, it needs work around how you might measure the implementation and process data. And then the final component is how can we use and disseminate and translate. And the different rows in there show that you can't just focus on inequalities, you can't just focus on childhood obesity or tobacco or youth drinking behaviour, but really there needs to be an integration of many of these different content areas together. That is, if you are looking broadly at a population group as opposed to individual areas, whether that be healthy eating, tobacco or other areas. So this conveys our program, which is ambitious, but it's also trying to integrate it and be transparent about the need to integrate it. This slide, for those of you who can't see it, just it's an example of the work that we've done in obesity prevention and demonstrates just the linkages that exist between epidemiology and knowledge translation, the time that it takes. We commenced this work in 1995 and are still doing updates of the Cochrane Review right now. But it's a long time, and so what that means in terms of long time is the need to create career pathways, the need to think about capacity over that time, to have people skilled and be able to work in this space over that time. And I think this is my final image, but it's really just conveying that for us to move ahead with knowledge translation, we need to have committed organisations, relevant research, all subgroups of the population included, a shared focus, and with all of those components, we should be able to make a difference in terms of improving health outcomes. Every project, every study, every evidence summary could have a logic model, and we've tried to apply a logic model to the conduct of our work altogether to try and think through how all of these different components relate together. It's hard, but it forces you to think ahead of time how different components sit together. So I'll move on to the partnerships. The partnerships we have at the moment are ones that have been established, some for a long time, some more recently. And the ones in red are the ones that I'm going to focus on today. So the first one I'm going to talk about is one with Merry Community Health Service. It's a community health service in an inner urban area of Melbourne. It's got a cultural diversity of 174 different cultural backgrounds and languages that go with that. And this partnership was catalysed by a research study, Fun and Healthy in Moreland, which was a 5-year cluster trial looking at childhood obesity prevention and health promotion. What's emerged out of that one study that didn't manage to get funded by NHMRC, quite a few rejections about it being a complex intervention and a complex evaluation, but did get funded by sport, recreation, education and human services. That stimulated or catalysed really the establishment of a population health research unit within that organisation, which continues to this day, so from 2004 ongoing. It has resulted in a commitment to priority research questions being established by the community themselves, from parent groups, mothers groups in maternal and child health, all the way through to the leads of the organisation. It's resulted and attracted in additional funding, so far ARC linkages, we're hopeful with NHMRC partnerships. There has been a commitment to capacity building over time. There are joint appointments between the university, and there is a vision, and a vision that has transcended as the CEOs have changed over time. The second one is one that was established a couple of years, slightly different origin. A tender was put out by the Department of Education and Early Childhood with a vision to do something about their population data sets, to improve the quality of them, to use them in terms of analysing them for contemporary questions and answers to contemporary questions, to build their capacity and skills around evidence-informed decision-making, but a very bi-directional, so a formal relationship, but also a lot of informal work as well. Progress so far on that one within the first 18 months, there's been clean data sets which are now linked and able to be used and follow up children from maternal and child health through to NAPLAN outcomes. There's been capacity building in terms of evidence-informed decision-making to all staff, and a number of co-written publications relevant to contemporary policy questions around vulnerability, around education and learning are just starting to emerge. So that's a new, embryonic. It's been challenging in terms of moving from a contract management convention, if you like, to a true partnership. It goes through wrinkles and tough times, but it's highlighting, I guess, the time required to invest in partnerships for good outcomes to emerge. KT for LG, some of you do know about. It was a study that we submitted to NHMRC, remarkably got funded in the first round. It's a cluster trial which aimed to look at whether different knowledge translation strategies were effective for local government. The most remarkable thing about this project is that within the 2 years in which the intervention was implemented, we just got a really fabulous insight into who's making decisions in local government and the turnover of staff within local government and the real sheer needs around training and capacity in local government for those who are working in positions where they were needing to work within an evidence-based framework, the municipal public health plans. So we had a range of people working in that area, from scuba divers to ex-police to people who had no training at all coming out of school being responsible for high level, and it really illuminated the depth of investment needed to and not the inspiration. Many of them were excited and engaged and wanting to move in this direction, but really needed a lot of investment in terms of capacity building. The outcomes of the trial itself have been really useful. The intervention group, with a range of networking, skills development, knowledge broking and evidence summaries, are much more likely to use evidence and much more likely to ask questions in relation to what the evidence is. And this one was set up really with the raison d'etre to help shift local government from short-term 3-month obesity prevention solutions to looking at the evidence and recognising that it needed to have long-term, complex, multi-level strategies tested and evaluated. There are some really good outcomes. 4 of the local communities ended up being local communities in the Victorian prevention investment. There's joint publications with people who've never published before, who never thought their words were of value, and many ongoing relationships. Nationally, some of you are aware of Co-ops, which is an investment by the Commonwealth Government in obesity prevention, and that itself is a knowledge translation and exchange mechanism and is being evaluated. And all of the subcomponents of that are included there. The next one, I'm nearly finished, is the Cochrane Public Health Group itself. And so what I've been trying to do now is to start to unpack, well, within all of these partnerships, is there a pull component? Is there a push component? Is there an exchange component? And how can we start to be a bit more explicit about which components of which partnerships are trying to achieve different outcomes and then evaluate them? A very contemporary one is the Australian Study of Children in Same-Sex Families, which is a global partnership with GLBTI community groups internationally, which has come up with contemporary questions that are really trying to answer international contemporary policy-relevant issues. And the important thing in terms of the Age editorial was stating that the data provides a rational starting point for discussing a topic that otherwise attracts an inordinate amount of myth-based argument. So finally, the outputs from the KT partnerships, well, there are priority questions and contemporary evidence. The evidence generation process, co-generation, co-production is incorporated into the business of the organisation, and then the business of the organisation is also incorporated into the research itself. And I think that's really important. Complexity in public health is normalised, it's transparent, it's embedded, and we put it on the table. Implementation data and process data comes to the surface. It has to be. CEOs want to know how long it takes to bring about outcomes, what it costs, who they need to staff, and so that information just becomes a normal way of doing business. It's inevitably solutions focused because organisations are moving forward, it's pragmatic, and the research is owned. I've got 2 more slides, but they're important ones. The essential ingredients that we've found is that leadership, vision and willingness has to be there. There has to be a commitment to sustained, productive relationships, and relationships, as everyone knows, in their personal relationships as well as their professional relationships, go through ups and downs. But it's that sustained commitment and that willingness to address conflict and work it through for mutual benefit needs to be there. The funding model needs to focus on form following function, and I'm not sure that we're there yet. And then, of course, you need all of that organisational and admin requirements, which we often don't give the high profile that within strategies that needs to be there in terms of doing the work. Have we got the right model for KT? Well, I think enormous developments have happened in terms of rigour and standards. How do we assess the trustworthiness of work in this area? So a lot of it, but I don't think we're there in terms of how we measure the outcomes of knowledge translation. I don't think we have capacity. As a group of professions, a group of organisations, as a population of people working in this area, I'm not confident that we do have a generation coming up through the ranks who can help support this yet, and we do need to invest there. Funding opportunities, I think generally they're disappearing. The amount of money swooshing around at a government level, at a non-government level, is generally disappearing. There are NHMRC and ARC partnerships, but it's hard to find the corresponding investment for those. So I think, and we're also challenged with philanthropics who still like bright, shiny people, machines, labels and buildings. And so us facing off against them is important. I don't think we've got the costings model right, and therefore we default into dissemination rather than more sophisticated knowledge translation. The research environment is still not quite right. It preferences push again, And I think we still have to work on normalising evidence generation in public health, which is there much more in the clinical areas, say cancer care or musculoskeletal areas. So in sum, knowledge translation requires a platform of generation, synthesis and exchange. It is a good direction of travel. There are applied issues, solutions and translation, but it's not yet well supported by structures, processes and importantly performance metrics. I still get assessed on how many publications I put out rather than how many partnerships and relationships I engage with. They need to be embedded as a way of doing business, and all parties need to work towards conversations where we sign up to these partnerships together from key principles. We need to better understand the impacts of these partnerships and evaluate the partnerships. Do they lead to better questions? And is the evidence more useful and is it used? And finally, our discipline-based structures at the moment and funding streams are increasingly anachronistic to this way, and I think we need to think through that a little bit more. Thank you.
All I can say, Gail, is probably get the bell ready. Okay, so I really want to tell a bit of a story, really, of what's unfolding in Victoria and not get, if I can help myself, too caught in the trap of describing in depth the nature of the intervention that's unfolding, but to really provide a bit of an opportunity to reflect on the very issue we're discussing today, which is the nexus between policy, practice and research. So I've chosen to actually share our journey in and around taking a very comprehensive, whole-of-systems thinking approach to preventive health. And I really do want to acknowledge, and I have the photos here to spark that acknowledgement, of 3 levels of government have signed up to enable a very different approach in Victoria. Which I think is quite exciting, other than the fact that there are 2 redheads there and there are 2 redheads here. And I don't know about you, but I don't see that many redheads anymore, so I'm not sure what that phenomena is. So, this is an exciting time, and I will acknowledge absolutely all levels of government in this endeavour. So I thought what I'd do is just do a really quick snapshot of Healthy Together Victoria as a platform for prevention, but really to introduce the construct, I guess, and the concept of complexity as really the area that I think we are faced with having to, with rapid speed, as Liz had certainly mentioned in her presentation, to get our heads around how on earth are we going to navigate complexity and uncertainty, because that is what the world is about. And it will challenge everything that we know and that we do and that we have been trained to do to move to a different place in grabbing this opportunity. And then I'll provide some reflections really on, as I mentioned before, the nexus of where I think we need to position ourselves moving forward if we really are going to tackle some of the very complex and wicked problems that we face as a public health community. I think there's no better way to show a story than a video, and so I will leave it over to...
This is the time to make a change that will impact on every aspect of our state, our businesses, our schools, our families and our communities. Through Healthy Together Victoria, we are making changes that place good health at the centre of our everyday lives.
I want to congratulate and thank all of you, mayors, chief executive officers, health department staff, collaborating partners, for taking responsibility for promoting health and preventing disease in Victoria. And over the years I've learned that the health of a population doesn't come from hospitals or doctors. It comes from a healthy environment, in the broadest sense of the word, environment.
We are very pleased to be one of 14 local government areas taking this new approach to improve the health of the people in our community.
Nothing like this is happening like this in England or America, in the way that we can be bright and clever and relevant to fight in the war of obesity.
This is a different way of delivering health and wellbeing to our local communities. And it's a brave but it's an exciting journey that we head off on.
So just to recap what's occurring in Victoria, so we have a multi-level, multi-system, multi-absolutely everything intervention going on, all timed and sequenced in a pattern of I guess excitement in terms of it's everything, every bit of literature has told us in government to do. It certainly doesn't tell us how to do it, but we are aiming, we're going big, we're going multi-strategy and multi-prong. This diagram really shows, I guess, the outer kind of sphere of an enormous amount of activity at the state level for all Victorians, but the inner three circles show the work that we're doing where we're targeting a set number of communities, around 14 local government areas in a complex community-based approach. There's lots here, but I will highlight one or two things to show the breadth of this intervention and in terms of its reach. We've established a Centre of Excellence in Intervention Prevention Science to support work across this literally from day one to integrate systems thinking into our approach and help us with the evaluation and the telling of this story. We've established a quality system for health promotion for the state in which there are a series of benchmarks you sign up to. That video is very much about promoting sign up. No matter if you're a supermarket, an early childhood service, a school, a workplace, a health service, sign up to being a Healthy Together organisation. We are redesigning the Better Health channel to be much more interactive around real-time information. People can kind of undertake a wiki prevention entry into a prevention system. We have a whole range and 3 levels of social marketing going live. And in fact, this Sunday, the Minister will launch our first localised social marketing strategy called Starts With. So there's a lot of activity. But I will highlight that Healthy Together Communities is a major initiative within Healthy Together Victoria. This is the part where we really wanted to try and pick up on that kind of movement of evidence and practice in and around really focusing on whole of community, but understanding that a whole of community operates fundamentally as a system. And within that community, there are multiple systems at play and there are multiple interconnections. So just to recap, 14 local government areas. We have 79 local governments in Victoria, but these 14 randomly selected out of a much broader group to have this intense investment over the coming years, represent about a quarter of the state's population. And they also comprise 4 growth area councils. I think one of them is the City of Wyndham is the highest and fastest growing council in the country, and they're very proud of their birth rate of 70 babies born a week. So trying to deal with prevention systems when there are houses being built by the hundreds of thousands is an extraordinary challenge that I think prevention really needs to be onto. Critical to Healthy Together Communities is the workforce that we've put in place. We have about 150 new positions, and the majority of those positions have been based in local government. And I guess that's the bold that the CEO of City of Wodonga Council talked about, the bold, brave move, is traditionally health gives its money out to health systems. Gives our money out to health services to run a prevention effort, but on this occasion we've decided to really have a much clearer line of sight between the state legislation. We have a Public Health and Wellbeing Act in Victoria and we have a State Public Health and Wellbeing Plan Every council in Victoria is mandated to develop every 4 years a municipal public health and wellbeing plan. So the line of sight through to the incredible role of local government and capability to lead a prevention, whole of community prevention approach was really timely for Victoria. I just wanted to highlight, people often will say policymakers don't get time and policymakers don't read the evidence, and why don't we take any notice of this really important evidence? It's it's not for dispute. Well, we actually do. We just do it really quickly. There is an extraordinarily rich evidence base, and mostly we like to think we're on top of it. At times, we really have to traverse these things extraordinarily quickly. But what we've seen emerge, I think, in the last 5 years alone is an incredible next level of richness. It's kind of highlighted to us the issue of complexity and complex community-level interventions. We've seen these emerging around the world as really experiments that we really want to take note of and start to think, how might we adapt this for Victoria? We've also seen the rise of systems thinking with WHO in terms of healthcare systems. We started to model, could this be possible for a prevention system? Why, when we have a health system and we have a healthcare system within the health system, wouldn't we have a prevention system? And if we don't focus on building a prevention system, we'll be left with short-term projects in prevention, which is certainly the history of prevention in this country, and I think something I'll be ashamed to see in the future. We're seeing additional work come up which shows us about taking notice of the whole of it, ice. It's very cold. The whole of an effort, not just the small parts of an effort, which is quite extraordinary. I just wanted to add that even this incredibly rich evidence base didn't tell us what to do. And we got very good clues on where we'd point our resources, but it certainly didn't give us a clue of how we'd shape things. So we've actually moved into looking much more at the complexity literature, much more around leading whole of systems change, much more around how you make decisions when you've got very complex challenges in front of you. So the underpinnings of HTV, we're applying, using, playing with, adapting multiple theories. This is really critical, right through employing a co-creation model in the way that we do what we do. We're looking at the building blocks of a system. We're focusing on the most powerful interventions of networks, leadership, communication, as really driving a momentum for a different type of prevention future. Really importantly, we are in the business of creating multiple health promoting environments, whether that's a school, an early childhood service, a sporting club, a whole community, a state. We really are in that, have that vision in sight. We do have an evaluation framework. It's constantly evolving. You can imagine with that level of activity and that range of interventions, it's very hard to work out how on earth you're going to evaluate. When you pull out some initiatives to evaluate, like Jamie's Ministry of Food, yes, well, you might, but overall we'll be observing through different types of methodologies, a number of which we have to adapt. In fact, what are the system impacts? What does that nature of that intervention occurring in this system at this time do for the prevention system? So in terms of the question of how we're tracking at the moment, one example from our evaluation is the quality system gives us a real-time look at how we're tracking. This has been live since the start of January. At the moment in the state, this is a universal program, so everyone in the state this is open for, not just our Healthy Together communities. At the moment we have around 22% of our primary schools signed up to being Healthy Together schools, and we have around nearly 35% of our early childhood services. That's quite enormous in terms of population reach. And as you'd expect in our Healthy Together communities, with the extra dose of workforce and early childhood being run largely out of local government in Victoria, we are seeing an even more significant reach from the Healthy Together communities. Workplaces, about 6 weeks ago, our quality program for workplaces come on board, and already we have about 90 workplaces signed up with a reach of about 35,000 Victorians. That's only after 6 weeks, so we're very excited. High media profile, lots of stories being generated regularly. The last 12 months I've never seen so much media, certainly at a community level right through to a state level, and even relatively positive media, which is quite good, and I think this is part of building a different type of narrative for prevention. We're seeing, this is an example from Healthy Together Bendigo, the enormous leverage of placing this effort in local governments. We're seeing changes to local legislation. We're seeing the rewrites of council plans, of municipal strategic statements, incorporating healthy by design. We're seeing sporting clubs be tax incentivised if they immediately adopt healthy catering policies in large numbers. So already we're seeing that traction of that investment in local government, which is quite exciting. And we have one of our methodologies is a system audit. So what's going on? What does the system look like? How is it operating? So there is an extraordinarily rich amount of evidence there in terms of how the current system's operating. and where we might intervene. Everyone would have seen this one, and this is just an example really of City of Knox, one of our local governments, and how they're mapping their local initiatives. A number of these initiatives are established and supported at the state level, but how they are mapping in their effort at a local level to influence the system, what types of interventions at what point over time. And in fact, when you overlay that with the richness of what the whole state's doing, it becomes incredibly messy. It's actually, you can't read it. So we're just keeping that a little bit simple now, but really important around interventions to match the different domains that can influence the system that operates. Really importantly, in the space of systems is understanding that the prevention system needs full consideration, a delivery system, an implementation support system and research system in and of itself as one to drive real change. Then we know this is the building blocks that we've modelled for Victoria, and really making the building blocks of a prevention system quite active. So we have a system thinking and acting workforce. We have leadership for systems change, not individual leaders, but multiple levels of leadership and a very clear and designed strategy to drive that level of change. I'll move on in the interest of time. Just one comment about the workforce. So over about 150 positions in total now. We've embedded field-based research and evaluation positions. There's communications positions, settings-based positions, senior kind of managers and leader positions. They all network at the state level, and they network across local government areas as communities of practice. When you talk of the term system, these are the systems that are at play that we have to deal with. It's not one or the other. So a workforce, a workplace is a setting, a school is a setting, an early childhood is a setting. But then we also have the education system, the health system. We have multiple planning systems. And over here in the corner, we have those systems that fundamentally influence everything, the food system, the transport system. So I'm regularly asked, particularly by local government, what am I going to do, the state government, around the transport system or the food system? But in fact, these systems are so fundamental to all levels of government. And I think understanding those interconnections and those relationships to get the most power of effect out of our interventions is really quite critical. I'll move on from there. Complexity has been really critical for us to understand, and I think this is the real challenge for public health. It's not just saying something's difficult, it's actually truly understanding complexity science and gearing up a workforce that is able to traverse that. We've been really lucky to come across the Cynefin framework, which I think describes this challenge beautifully, in that we, I think, in the public health community approach the world largely as it being ordered, but in fact most of it is unordered. And what the Cynefin framework does is move us between understanding that some things are simple, and we welcome them and enjoy them in our jobs when they are simple. We just simply have to respond. Hand washing for infection control, nice and simple, a rule of procedure. Some things are a bit more complicated, and I think this is largely the domain of where we operate in public health. We we analyse and we respond. But I think the new gun is complexity, where in fact it's about emergence, it's about what's happening, real time, what will happen next, being really able to traverse the space of complexity. Probing, sensing, responding, constantly probing, sensing, and responding. And chaos, which none of us would ever experience, I'm sure, in our daily kind of lives. Is that it? Yeah, that's fine. So I think the real challenge for us is now, if we're approaching systems, do we look at it from through the minds and eyes of engineers? How do we design and engineer these systems? Or do we actually embrace systems for the exciting, complex, continuous learning opportunity that presents? And I think this will be undoubtedly one of our greatest challenges, because it's about foresight, not hindsight. And I think most of us have come through disciplines in which grabbing, looking at the moment and looking back has been one of the most powerful ways of telling the public health story. I'll need to finish up.
That's okay. Well, you can
just one or two. Okay. Well, no questions. I'll get up questions later. Look, I think this is quite important. The new frontier. I think no matter what our methods, no matter what our policy or our practice employs, in fact, narrative and the power of really large-scale human metadata and how we capture that. And when we're trying to undertake an intervention, as we are in Victoria, we really are seeing effects happening with tens of thousands. So how, in fact, do we capture the impact or what's going on across the tens of thousands, whether they're volunteer health champions, the 150 workforce, the schools that are implementing health promoting schools kind of guidelines and the workplaces. So we've been experimenting with a program called SenseMaker, which enables us to really capture this large-scale data. And I think it really presents a very exciting future. We trialled it a couple of weeks ago with the workforce. I think over a 3-day period we had over 800 stories or narrative. And the capacity here is not just about entering, and in fact we can enter real time on our iPads and on our iPhones. It's much more about it. 5 o'clock Friday was our cut-off for our stories as a whole system across the state. 1 hour later, we had our first analysis of what's going out across the system. So I could observe patterns across the state of how things were going with the quality program. How were mayors responding? Oh, there's 3 or 4 clusters of mayors, leading things in a different kind of direction. So that is the power in embracing a sense-maker kind of technology. And we aim to employ this a whole lot more in the future in and around real-time, large-scale narrative, feedback, and our capacity to respond and tweak the system at wherever we are working within the system on this journey. Okay, so the new narrative for public health, we've got a workforce now in Victoria that commonly use this word, sometimes a little bit too much probably, but it's a different language. It's not the traditional language of public health. This is the language around activation, adoption, engagement. We're emerging now in praxis, which is theory-based practice, as being really prominent because surprise and shock research comes from practitioners. And that's really critical. We're talking feedback loops, we're talking multiplier effects, we're analysing interventions and timing them in terms of their impact in the system. What will be the ripple effects in the system? Would we choose that intervention over that intervention for a system impact, and is it different? And in terms of narrative, in terms of how complex our challenge is, here's a 2-page spread in the Herald Sun not so long ago about ditching the sausage rolls in a community in central Victoria called Ararat. Well, guess what's happening to Ararat? Ararat has been selected to host the first community Biggest Loser. Yes, I'm talking about Channel 10. So this has had an extraordinary impact in this community because the biggest loser have arrived. They've selected the 15, they've got to slog it out. They've selected another 500. Literally thousands of people are turning out at boot camps. Thousands of people are walking day and night in Ararat. The supermarkets are running out of healthy food. The restaurants are changing their plate serving size, and it's all happened in a period of 2 to 3 weeks. Now, is there anything we could possibly do in our toolkit in public health that would create that kind of demand for a prevention system? Probably not. So we are certainly observing through the narrative capture what's creating this rapid change. And no, it isn't about appearing on telly. In fact, that's the greatest fear of people. They don't want to be on telly. But something has turned this community around, good, bad or otherwise, and I could be on either side of that debating team. But really, things are happening out there which are major events in systems that we need to be cognizant of. Okay, just to finish, the proposition around the nexus. I've had a couple of researchers still smiling but often not smiling, and I think when you work in this space together so closely where the seamlessness of the policy research practice, it's just, you have to have a seamless relationship. There's times research just has to do what research does best and be left alone by we policymakers. But in this space around complexity, it is much more about working very closely together in co-producing. And at times we have torn our hair out, but I'm sure that's not why Boyd Swinburne and Alan Sheil looking like that. But it's been really difficult because we've had to design methods at the same time we're applying methods, as well as try and provide direction, but know within a complex adaptive systems intervention, in fact, you just provide notional direction and you allow the system to monitor itself, and you intervene at different points along the time. So it's a very new way of doing things. And so I think I've talked about most of these things, but if I were to have 5 or 6 principles for practice in moving forward as a public health effort around complex issues, then they'd certainly be around collaboration, and true co-production, as painful as it is absolutely critical, right through to looking at and exploring new types of methods, system dynamic modelling, social network analysis, concept mapping, alongside of more traditional research methods, but certainly much more large-scale human narrative capture. To me, you can see this plethora of fantastic methods, and some of them are interventions in and of themselves, which will be very powerful for moving a population. Well, that's certainly our hypothesis. So just to finish up, as I mentioned before, the complex space, it is incredibly difficult and there is no roadmap for it. But I have to say and it will challenge us all, but most days I would not want to be anywhere else. So thank you.
Thanks, Gail, and thanks, Anne, for the opportunity here. And I want to start by acknowledging the traditional owners of the land, the Ngunnawal people, and pay my respect to their elders past and present. I also want to make it clear, just in case you weren't clear, I'm not one of the redheads that Shelley was referring to, but rather one who tore his hair out. So, look, I would like to start by actually reflecting. I think Shelley was talking a little bit about policy development, and I've called my presentation Creating Policy, and I think a lot of researchers sometimes think we don't take a lot of notice of evidence, but in fact we do, and we actually have a good understanding of a lot of evidence, but as Shelley says, we work in a very dynamic, complex system, and sometimes we make decisions very quickly, or sometimes it takes a lot longer, and sometimes obviously the timeframes are very different to what researchers work in. And I think in terms of creating policy, important concept I want to talk about is really it's actually about change management. And research is one part of a change management agenda, but researchers really shouldn't be actually looking at just their part of it as what they need to focus on. They actually need to look at a whole change agenda, because that's what policy is all about. How do we change things? I mean, you can have a policy position that says we're not going to change anything, and that's quite legitimate in some instances, although quite frankly we work in a very dynamic, changing world, and we are forever actually dealing with change on a daily basis. And if you think, one of the examples of prevention that is still thrown up to me is the advent of seatbelts in the 1970s, and what a great difference that's made on the public health. But if we were still driving in the same cars with the same seatbelts on the same roads and with the same laws that we had in the 1970s, then we would have a lot more deaths than we have today. And we've obviously seen change happen over an extended period of time. And that's reflected a lot. I mean, even in cultural change, you can see where young people today are not drinking and driving like they were in the 1970s and 80s. So we have actually seen quite significant change, and it's been built up over time because of the changing environment. So I think you really need to think about policy development and creation, and the use of evidence in creation of policy as a part of that change agenda. And you think about it in the context of saying, what problem are we trying to solve? I mean, that's obviously your research question. And I think often people lose sight of actually getting back to why we're doing this. And, it's one of the issues that I've had to talk about a lot over the past few years when we're talking about national health reform. What problems are we trying to solve? And you go back to actually the changes we're making have been very much about improving equity, access, and also trying to do things like sustainability of the Australian health system, reorient towards a stronger focus on prevention, primary health care and so forth. So you really do need to focus very strongly on what problem you're trying to solve. You'd need to think about the environment, what's possible. It's not often possible to turn things around 180 degrees. You actually have to work in the environment that you're in, but the environment keeps changing. It's great to be a leader, but being a leader is very different to being isolated. So good to be out in front, but if you want governments to support the research that you've done and the evidence that it creates for policy development, then you've got to have government convinced that you have actually got the people behind you, that you've actually got support for what you're going to do. It doesn't necessarily have to be majority support, because that majority support can follow later on. But if you've got dissident voices talking about the same policy issue from a different approach, then it's very likely that you're actually not going to get a lot of attention from governments in terms of policy change. And again, reflecting on what Shelley says, we work in a complex system. So you really do need to be thinking about the system in which you operate and what's happening in the broader environment, and how does what you're doing actually contribute to that broader environment and the longer term goals that governments may have. And again, that's actually recognising that that's a dynamic system. But how does it fit in the big picture? What's it build upon? Again, if I look at what we've done over national health reform over the past few years, a lot of people, potentially would say, well, gee, we haven't got the system right yet. And I would first off say it's early days, and these things take actually some time to bed down. I remember an introduction of Medicare. It took 3 elections before there became bipartisan support for Medicare, and that finally did happen. A lot of the changes that have been introduced will obviously take time to actually prove their benefits, but I always keep saying to people, look at it as an opportunity, because we know it's going to change, so build on the opportunities that are being provided by those changes that are being put in place. And policy making, very dynamic and very opportunistic, and timing is everything. I mean, if you think about a good example, John Howard with gun control. We obviously had a tragedy in Tasmania that enabled the Prime Minister to take the leadership there and have the Australian population back him in relation to gun control, and what a great success that was. But it was very opportunistic. It needed a tragedy, and it's very interesting to look at that as compared to the USA, where you've actually had lots of tragedies, but you haven't had the change happen there because you've got a very different environment. So Australia is obviously very different to other countries in that context. There's also an issue I think that's important to take into account when you're thinking about change, is that there's an issue about how much change you can actually do at any one time. Trying to bite off lots and lots of complex issues at the same time just causes confusion in the public. So it's actually about being able to move your change over time through a complex system where if you poke one bit, another part might poke out. So it's actually about how you manage change. And if I think about, one important thing, money. We don't have any. Every new policy proposal that we put through in government these days has to be offset by saving somewhere else. So grandiose ideas about spending lots more money is obviously a great difficulty. So you've actually got to think about that. What's the benefit? Actually, what's the value? Very important issue. Some of you will probably know the management guru John Kotter, and if you think about Kotter and his 8 steps to change, he presents a process that you go through in relation to change management, and the first of those is about establishing a sense of urgency, and that's your research question. What problem are we trying to solve? How can you actually make that a really dynamic research question that can actually identify a problem and is easily understood and sellable to policymakers? Secondly, create the guiding coalition, and I think Liz and Shelley both touched upon this. Where are you at in relation to having support for what you're trying to achieve? Where are the consumers, the policymakers, the providers? Have you got the level of support there in terms of the guiding coalition, rather than expecting government to go out and say we're going to do something which is totally unpopular? Developing a change vision. I mean, the change vision is actually the research outcome, if you think about it. And a lot of people actually just stop there. They think, well, okay, here's the change vision, go away and do it. But that's actually only the 3rd step in Kotter's 8 steps. There's a lot more that goes on after that, and I think researchers actually need to take that into account when they're saying, okay, well, here it is. It's actually about how you take it forward and how you implement it. The 4th one, communicate the vision for buy-in. A logical thing again. I mean, how do you actually get the momentum going for others to support what are good ideas and where there's evidence. Empower broad-based action, a logical thing that's about implementation. How do we actually go about implementing it? You need to think about implementation strategies. Generate short-term wins again. I mean, if you think about government focus, you're obviously, and the cycle of election cycles, and I talk about dynamic policy making, I've got to say to you, as elections get closer, the dynamic cycle gets faster. You've got to actually generate short-term wins so that you can consolidate the changes that you're trying to put in place. Never let up, and I'll come back to that because I've got some great examples of that. And then incorporate change into the culture. And again, this is the reflection that all 3 of us have been talking about this is a complex system that is forever changing, and you need to recognise how you can influence that system by the application of evidence right through the process rather than as a standalone issue. If I use as an example tobacco, I mean, I've got policy responsibility for tobacco plain packaging, which is a lot of fun, but it's not as if tobacco plain packaging has been done in isolation. If you talk about never letting up, this is 40 years of work by many dedicated people where we have actually positioned ourselves so that the next logical step in policy in relation to the promotion of tobacco control is actually tobacco plain packaging, and which is why, given the 40 years of work and the multitude of things that we've done in a complex area, we are actually able to move to this, whereas other countries have not gone through the same pattern, and are actually, the next logical step for them would not be tobacco plain packaging. But it is a complex issue that has been built up over a long period of time. It's a never letting up issue, and it's actually about cultural change, which we have achieved quite substantially in Australia. If you look then at another example such as alcohol, we are actually in a different situation in relation to alcohol because we don't have the same build up over time in terms of cultural change. And I've heard people say, well, we should move to alcohol plain packaging. Well, it would actually be extremely difficult to do that. You wouldn't actually get government support, community support, because it's a step way down the track where, who knows, there may be time, but over time, the population will change in their views on that. But more logically, at the moment, there is a lot of focus on alcohol in relation to access, in relation to promotion, in relation to opening hours for where you're ending up with a lot of people, young people in particular, ending up damaged in emergency departments. So I think the mood for change in some of those areas is actually much stronger. And probably finally touch on primary health care. I mean, one of the areas, one of my responsibilities is on primary health care reform, the establishment of Medicare locals. And again, if you look on Medicare locals as a vehicle for change, they're not an end result in themselves. They're actually a vehicle that we're putting in place so we can reorient the Australian health system towards that focus on prevention, early intervention, chronic disease management, keeping people out of hospital where possible. I think this is an area where, again, for researchers, it's an important area where we need to look at the next steps. Can we work on reform that does reorient the Australian health system through primary health, a stronger focus on prevention and primary health care? Medicare locals are there as the vehicle, they're ripe for actually changing the system, but we actually do need that bringing together of policy and research and evidence to actually put in place the change. But as I say, it's the whole process we need to focus on, not simply the evidence. Thank you.